To get a sense of how related addictions are to other psychological disorders, at least in the clinical view of the world, here is the Diagnostic and Statistical Manual's first crack at defining addictions. Whether the addiction was to alcohol or drugs of any kind, if you had an addiction, you by definition had a personality disorder, specifically a sociopathic personality disturbance, further subspecified as addiction to either alcohol or drugs. This might be a good time to pause and see what else in the 1952 DSM First Edition was a personality disorder. Wetting the bed, sexual deviation, and yes, same-sex attraction was covered by this diagnosis, passive aggression, and probably my favorite, inadequate personality. Does this mean you're boring? What is an inadequate personality? Well, such individuals are characterized by inadequate response to intellectual, emotional, social, and physical demands. They are neither physically nor mentally grossly deficient on examination, but they do show inadaptability, ineptness, poor judgment, lack of physical and emotional stamina, and social incompatibility. Fittingly, inadequate personality proved to be an inadequate personality disorder and was gradually removed, going from the main body to the appendix of the DSM-2 and being incompatible with DSM-3. The current batch of accepted personality disorders are these. For a detailed look at them and at other perspectives on personality function and dysfunction, see my abnormal psych lectures on them. If you learn enough to avoid having your life destroyed by just one cluster B personality disordered individual, then an entire certificate or degree in psychology will have been worth your time. A key distinguisher is that these individuals tend to mistake having leverage on you for being correct or loved or morally righteous. The fact that they could give you a B or an F for disagreeing with them, or could complain to your boss about you, does not mean that they are in the right. Avoid entanglements with cluster B. Don't do battle or submit. Don't rescue and don't validate unless you like the idea of being stuck doing so in perpetuity. Just walk away. The next few minutes of video throws a bunch of numbers at you in order to let you know what you can expect in the world of addictions. A general rule of thumb, or heuristic to follow, is that you should expect roughly half of the individuals with diagnosed addictions to have at least one other psychiatric disorder. This number will of course be higher in clinical samples, i.e. if you're working in a clinic, because individuals with multiple disorders are more likely to need more help and thus be in the clinic, and the prevalence will be lower than 50% outside of clinical settings, since you are most likely there to see alcohol addiction, which has lower rates of psychiatric comorbidity than at least other substances. Let's start with a non-clinical sample and look at rates of comorbidity there and how we might estimate them. This study conducted interviews face-to-face in two phases. A screening phase with an adult resident of the household and a computer-assisted self-interview phase facilitated by a laptop with headphones into which the interviewee could type their responses to questions about their psychiatric symptoms, if they have any, their substance abuse, and other sensitive behaviors we typically would not like to talk about openly. From nearly 68,000 interviews with adolescents and adults, the researchers noted that 39% of interviewees who met criteria for substance use disorder diagnosis also met criteria for one or more other mental illness. When you compare this group of substance use disorder qualified individuals with the other participants who did not meet criteria for any substance use disorder, 16% of that group that could not be diagnosed with substance use disorder met criteria for any other mental illness in the past year. Note that the millions listed in the bubbles are extrapolations under the assumption that the interviewees, the 68,000, are representative of the larger U.S. population. Taking some time to digest this diagram, you will see that you are far more likely to see other psychiatric disorders in a group of individuals with addictions than you are to see individuals with addictions in a group of individuals with other psychiatric disorders. Even in a non-clinical sample of persons with addiction, you can expect 1 in 3 to have another disorder. Compare that to just 1 in 6 people with other psychiatric disorders having an addiction. Okay, what types of disorders should we expect our clients with addictive disorders to have? Affective disorders and, not surprisingly, given the introduction to this video, personality disorders. Some relatively high base rate examples include smokers having far higher rates of depression than non-smokers, alcohol having multi-generational relationships with depression, internet addiction being linked with depression and, not surprisingly, insomnia. And these relations tend to show related improvements. That is, treating the addiction tends to alleviate the depression, and not treating the addiction, when treating the depression, tends to decrease the likelihood of the depression treatment succeeding. Before we get into personality disorder, comorbidity, a word of caution. Personality disorders are supposed to be disorders for which we have a pattern of behavior going back to adolescence or earlier. If that disordered behavior or disordered way of being can be attributed to the addiction or to the substance, many will preclude the possibility of diagnosis of personality disorder. If you, as a clinician, cannot get a clear picture of what the client is or was like absent the addiction, then it's arguably not fair game to diagnose the personality disorder on top of the addiction. It is also desirable to prioritize treating the addiction over the personality disorder where such priorities have to be made, in part because the other problematic ways of being may cease or change as a result of treating the addictive disorder. That said, the directional arrow between personality disorders and addictions has two heads. Those with antisocial personality disorder are more likely to break the moral and societal rules meant to protect them, and those with such a disorder who also have cravings or withdrawal are more likely to engage in a manner that gets them on the radar of law enforcement, parents, and bodies like Child Protective Services who might funnel such individuals into clinics or professionals who affix the personality disorder labels, leading to those individuals being diagnosed. We can be more specific here and say that addictions lead to what used to be called regressive behaviors, meaning those one would expect from a younger person. The more regressive the behavior, the more like a baby it is. Examples of regressive behaviors include impulsivity, inability to delay gratification, or having low frustration tolerance. Impulsivity is a natural consequence of the terrible biological state that is craving and or withdrawal. Self-centeredness characterizes regressive behavior that tends to lack empathy and compromise. The self-centered individual emphasizes the way they are unique from others, ignoring the fact that things like risks and consequences apply to them as well. This is a lesson that some people learn earlier than others, often through tragedy or other circumstances that give perspective and teach the individual that they're not immune from what they admit others are vulnerable to, but might have trouble admitting they are vulnerable to. Stimulant addiction tends to have a profile of self-centeredness, for example, and feel free to ask yourself here what exactly it means or implies to say that a substance seems to have a personality profile. Other regressive behaviors include passivity, sometimes impolitely called mental laziness, or more charitably described as feeling helpless and being withdrawn. This sounds rather like it would be related to depression or the cluster C personality disorders. Finally, affect intolerance, which describes difficulty recognizing feelings, fear of feelings, decreased ability to endure or regulate emotional states. Again, the relational arrow between personality or ways of being and substance use is bidirectional. Neurotransmitters change and social fallout of behavior changes one's context, and these can loop together such that looking for a cause or a single spot to stand in order to interrupt the whirlwind of addiction is not necessarily a straightforward process. Substance use can influence bodies, such as when those with addiction cannot enjoy sex when sober, and bodies can, of course, influence substance use. A term for how much one's body tends to react to substances is the dose-response curve. And we each have our own, such that some of us may have a religious epiphany at a given dose of a substance, where others are merely amused, or in some cases terrified. Since I promised you numbers, here we go. From page 574 of the DSM-5, we see that smokers are far more likely than non-smokers to have most psychiatric disorders. When we add in the requirement that the smoker must also experience withdrawal symptoms when they do not have nicotine, the relative risk tends to increase dramatically. We call smokers who experience withdrawal nicotine-dependent smokers, and these individuals have far higher rates of other mental illness than ex-smokers or even smokers without withdrawal symptoms. Comorbidity results are not quite as dramatic for cannabis use disorder until we get to youth samples. Keep in mind that these numbers are your risk of having these disorders given that you meet criteria for cannabis use disorder. So, should we say that marijuana use causes 60% of problematic users to develop externalizing disorders? It may, but the arrow goes both ways, and the current fashion in treatment is actually to see the substance user as self-medicating. In other words, to see the psychiatric issues as causing the substance use and not the other way around, at least when working inside the addiction's labyrinth. Other comorbidity numbers include if you have had any other substance use disorder, then you have a roughly 50% chance of developing an alcohol use disorder in your lifetime. Of those on methadone maintenance treatment, for example, recovering opioid users, 90% are smokers. And of those in inpatient treatment for alcoholism, 90% are smokers. And if you would like some base rates against which to compare these 50% and 90% risk values, Statistics Canada in 2012 noted that Canadians' lifetime prevalence rate of having a substance use disorder, that is, any given Canadian's overall chance of developing an addiction to a substance at some point in their life, is 21.6%. Specifically, 18% for alcohol, 7% for cannabis, and 4% for all other drugs lumped together. Two things to point out are that these numbers may be a bit out of date, though they should not change too much, and that these are lifetime prevalences. Your chance of encountering something over the course of your entire life is much greater than your chance of encountering something in just one specific year of your life. I'm far more likely to meet Wayne Gretzky over the estimated 75 years of my entire life than I am to meet him tomorrow, or specifically in the year 2025. Lifetime prevalences are much higher than the normal yearly prevalences that are more typically reported. Compare these lifetime prevalence estimates to the yearly prevalence estimates from the same year, 2012. So, if having a substance use disorder does indeed raise my risk of also having an alcohol use disorder to 50%, it increases my normal base rate risk by nearly 10 times, i.e. an order of magnitude. With these yearly prevalence rates in mind, and just to be clear, these numbers are your chances, all other things being equal, of having these substance use disorders in a given year. With these substance use disorder prevalence rates in mind, we can shift to prevalence rates of personality disorder and then look at these rates in comorbid groups. Since personality disorders are supposed to be lifelong, lifetime prevalence rates will suffice. According to Statistics Canada in 2015, these are the most prevalent personality disorders in Canada and their lifetime prevalence rates estimates. Now that we have overall population base rates for substance use and for personality disorders in hand, let's see those rates in subpopulations with disorders. In a community sample, where we would expect comorbidity to be lower than in a clinic, of those with current alcohol use disorder, 28.6% have at least one personality disorder. Of those with a current drug use disorder, nearly half have at least one personality disorder. So that's the risk of having a personality disorder, given that you have a substance use disorder. Recalling the earlier interview with headphones study, we would expect the risk of having a substance use disorder, given you have a personality disorder, to be lower than this. And it is. What these community samples tell us is, if you meet a random person with a personality disorder, there's a fair but not huge chance that they will also have an addiction or two. If you meet a random person with an addiction, there is a good chance that they will also have a personality disorder or two. But let's assume that we are predicting who will walk into our clinic. Here we want clinical samples. Clinical samples have more comorbidity. Of those with a current substance use disorder, in this particular clinical sample, more than half, roughly 2/3, had at least one personality disorder, and 35 to 50% had at least two personality disorders. Yes, people can have more than one personality disorder. The number of personality disorders one meets threshold for is an index of how severe or pathological one's personality dysfunction is. Other clinical samples contain similarly high rates of comorbidity, or rates much higher, including samples with 100% of substance users qualifying for at least one personality disorder. The disorder names and descriptions may change over the years. Recall that addiction itself used to be a personality disorder, but through these changes, the comorbidity rates stay high. Best practice is integrated treatment, where you have teams working together to treat all of the comorbid disorders at once in a coordinated and individualized and specialized manner for the client. In the real world, with limited resources and unreliable parties, you may have to prioritize the addictive disorder and hope that the other problems, be they affective disorders, personality dysfunctions, or others, to hope that these other disorders are helped by addressing the addiction or addictions. That's enough for now. Your homework is to list some substances that you admit have a degree of control over you. In actual fact, the homework is to come to terms with what that phrasing might mean. What would it mean to admit or to think about a substance like sugar, caffeine, salt, nicotine, alcohol as having control over you? That's probably not how you think of it by default. What are the implications of thinking that substances control you? And in that case, shouldn't we call them superstances? Opioids, fruit flies, and dopamine. Next video. Stay tuned.